that same energy, the same information as we're thinking about it in the moment that we're in addressing parallel pandemics, because certainly as we're looking at this rapidly evolving emergency that we're sitting in and we're addressing and we're dealing with and navigating through, we know that there's ongoing pandemics that communities, Black and Brown communities, Indigenous communities have been facing for centuries. And so we always have to make sure that we do not lose that narrative. And it is certainly part of the work at the New York City Department of Health in sort of making sure that we are thinking about the ways in which we're addressing longstanding health inequities. And so it is a pleasure and an honor to serve as the inaugural Chief Equity Officer. The principles of our agency, the core foundations of our agency are three: science, equity, and compassion. It is the core of our work. We use science to make sure that we're informing the work that we do. At the crux in the center of it, the nexus of our work is equity. And that has to hold all of our components together, the tools and the interventions that we use, and certainly leading with compassion and thinking about the tells of two cities that we live in and the vulnerabilities that exist. And so thinking about how we're meeting this moment, we're certainly focused on this resurgence and making sure that we're preparing for mass vaccination. But we're also thinking about the core public health work that we've been doing for decades and making sure that we're advancing an anti-racist public health practice has been part of the work of the agency during this administration, so for the last 6-7 years. And so happy and honored to serve under the leadership of Dr. Mary Bassett and Dr. Arcides Barbeau, and now the Commissioner, Dr. David Chosky, where we're continuing to advance a racial social justice lens in our agency. And part of that work has been elevating this position of a Chief Equity Officer to make sure that we're aligning our internal and external work. And so I'll talk a bit about what we're doing during this response and how we're meeting this moment. But I think it's always important to sort of ground the conversation in sort of where we are and how we frame our work. And so we look at it from a place-based lens as it's very important to be able to understand the inequities that exist in New York City. And looking at our outcomes, and many of you have probably seen this map time and time again, but it's important to contextualize. Yes, we see that people are dying, but the question is where and why. And we do see patterns of where people are bearing the heaviest burden of disease and social and economic instability in New York City. And Central Brooklyn is one of those locations. As you'll see in the maps in front of you, even for these health outcomes like infant mortality, premature mortality, dying before the age of 65, and even life expectancy. So the inverse, and sort of seeing that individuals are dying young and experiencing excess premature mortality, all situated in the same areas, the South Bronx, parts of Upper Manhattan, and then also in North and Central Brooklyn. And then you'll start to see some of those patterns start to show up in Queens. And so I'll address that as I go on, of why we don't always sort of see Queens light up the same way as the other boroughs, given the diversity that is in Queens. So even thinking about other health outcomes, HIV diagnosis, psychiatric hospitalizations, you continue to see the same patterns. That this isn't, widespread, but this is certainly situated in specific areas of New York City. And even when we look beyond to other social indicators, poverty, elementary school absenteeism. So thinking about missingness from school for more than 30 days, or even jail incarceration. that pattern is there, and the point of it is really to make sure that we contextualize that this isn't, that health outcomes are not driven by biology or genetics, but this is absolutely external factors. These are social and economic forces that have led to these longstanding health inequities. And so, data is really helpful when we can contextualize the information, when we can talk about the historical marginalization of groups and understanding the history of colonialism. We just wrapped up the celebration of Thanksgiving, and understanding that the history of Thanksgiving is also a history of tragedy. And given the First Nation, the indigenous people who came, who were already here, and understanding the ideologies of white supremacy being rooted in the development of this country. And given that this country is relatively young, 13 generations going through legalized capture and slavery, and then in 4 generations of segregation. And now we can say that we're legally free, but we're still dealing with the impacts of the policies and practices of both the American slavery and also segregation or Jim Crow. And so we know that we're still feeling those impacts, and certainly during the summer, dealing with the death of George Floyd and so many others, we know that there's so much more work that has to be done. In public health, I see, and that's the reason why I joined a public health agency, because I see public health as a way in which we advance social justice and address racial injustice. And it has been an opportunity to really push this agenda in the work that we do beyond just access to care. And so where we are now, like, as I mentioned, we're sitting in this pandemic, but this pandemic has certainly amplified the inequities that we see, the differences, the disproportionate impacts of when you have an assignment of value to one's color, to one's social position. And so that has led to why we're seeing these racialized impacts of COVID-19. This, what you're seeing before you are the state and city data milestones that we continue to use. And so percent positivity, hospitalizations, and a number of new cases. But when you push beyond and understand disaggregated by race and ethnicity, you can really begin to see the differences. And as Dr. Frazier had already mentioned, that there have been communities that have disproportionately been impacted more than others by COVID-19. And so it becomes our responsibility, the health department, health systems, organizations, to really make sure that we're looking at ways in which we're closing the gap, in which we're reinvesting or providing more ways and interventions to address those inequities. And that work does not fall on one organization or one agency. It has to be a collective approach. And these are the ways in which we can really operationalize an equity agenda. Part of it is also understanding where those missteps have happened. And even as an agency that has been prided on including an anti-racist lens and really talking more about health equity, we understand that there are a lot of missteps that we have even been part of as we look at previous structural or previous emergencies that we've responded to and how structural racism has shown up. You can think back to the Zika response back in 2016, and during the Zika response, testing was also really, really important, particularly for women of reproductive age, women who were traveling to Central America, to South America, and understanding that those testing resources were not equitably allocated to all hospitals, safety net hospitals, public hospitals, which really caused a lot of issues with really being able to identify families who are part of undocumented families, or families who are in certain neighborhoods, not having access to Zika testing, really shown some of the inequities during that response. And the same for during Hurricane Sandy, particularly because of the history of redlining and the ways in which disinvestment had happened in certain neighborhoods. Emergencies and these crises really do not provide the bandwidth or the wiggle room to really allow for individuals to be prepared for an emergency. And so the resources that are allocated need to be equitably allocated to make sure that we're supporting families given history of disinvestment. And those are ways in which we're thinking about it now. And certainly as we've shared this data of individuals who've been impacted by COVID-19, we have been intentional about how we have thought through our interventions, and we've been thinking through the ways in which we are making sure that we try to respond to this resurgence that we are now in. So when you think back to April, March, and the headlines that really sort of amplified the persistent, systematic, intergenerational racism that we've been confronted with, certainly one of the ways in which people have always talked about or have been talking about the need to provide more testing to make sure that we have been getting more resources out to communities. But the call was much larger. The call was much larger to figure out how do you really change institutional policies and practices so that we're not constantly repeating these inequities. And now that we're in a resurgence, certainly those conditions have not been fully removed or eliminated. And so we're certainly seeing those inequities even today. In other jurisdictions, we continue to see high rates of cases among the Latinx population. Certainly in other parts of jurisdictions, we're continuing to see Black communities disproportionately impacted by COVID-19. During wave one, as we call it, or the initial phase of this pandemic, we certainly saw high rates of death among Latino population was 3 times that of white population in New York City. And then for Black communities, that was 2 times the rate of the white population here in New York City. Understanding sort of what has led to those inequities wasn't just access to care. And so some of these headlines sort of talk through some of the systematic issues that really reared its ugly head during the first phase of this response. And part of our work has been to not only identify it, but also to figure out ways that we address those issues. And I think it's always sort of framing it as how we think about health. I think one, it's a narrative change. It's making sure that we're clear, not always placing blame on or victimizing groups. You remember early on in the pandemic, the focus on China and blaming China for the spread, when we knew or began to learn how the spread started from Europe, or even in America, even in New York, this focus to stigmatize Asian American communities here in New York City, and then beginning to blame or talk about how communities were not following certain guidelines or effective prevention measures. So it's a shift in narrative that is so important in how we use data, how we're telling that story, and how we're dealing with risk communication. And I think data is really important, not only the quantitative part of it, but also qualitative. And so using numbers, but also making sure that we're using qualitative information to be able to really contextualize the concerns and issues. Then it's also not really focusing on just the outcome, right? Someone is sick, someone needs to be tested, someone dies, but it's also understanding the factors that really lead to those poor outcomes. And so the living conditions, also understanding the institutional changes that are needed, and really working with hospitals to really address those changes that are needed at at staff levels and even at an institutional level. And so we'll talk a little bit more about the ways in which we've been trying to work with healthcare systems to even make sure that they're responding to this moment and addressing communities of color. And this has certainly been a national focus. I showed you some of the headlines, and here are some of the examples that are happening in other jurisdictions. And we have been in constant communication and collaboration with other jurisdictions to talk through their equity response. And so in Chicago, where they recently named a chief equity officer at the health department and also a chief racial equity officer in the mayor's office, has implemented what they're calling their racial equity rapid response team, where they are bringing together traditional and non-traditional partners, healthcare, community-based organizations, the health department, the mayor's office, also academic partners, to use data, to use resources, to really make sure that individuals are being connected to testing resources and be able to safely isolate. But then there's also a way to really address some of the social and economic instability. So that's in Chicago. In California. So I think that there are three main points that I really wanted to make sure that I got across. And particularly we're talking about advancing an equity agenda. And no matter sort of where we are in our professional journey, and particularly for those who are starting off and early on in their career, I think the important part is I do think public health is going to be a key role, no matter what your specialty is or however you are contributing to this conversation, because public health sort of really sits at this idea of how we are activating communities and really thinking about a place-based lens. And I think an important part of really maximizing our public health principles is making sure that, one, we're using our data in a responsible way. How we talk about our data and not just those inequities and saying Black people are 3 times more likely, fill in the blank, but really sort of making sure that we're contextualizing those inequities in a way that we're also integrating the social and economic instabilities, living conditions, and certainly the historical traumas that have happened in this country. That is really the way in which we get at closing the gap, is making sure that the historical context is part of the narrative. And we can use the narrative in a way to really make sure that we're highlighting these injustices, and that is a responsible way, but also finding solutions. And generating those solutions mean also telling the story and also integrating the voices of those who are really living the experiences. The second part is thinking about our interventions. Our interventions are robust, and we don't have to just thinking about it as clinical practice. Clinical physicians are key, but really are not the only answer. And certainly, if we're going to be successful, we really have to think about this as a collaborative approach, and really thinking about how we're bringing housing specialists, social service specialists, researchers, physicians, also thinking about doulas and community health workers to the table, and to really think about how we can really work together and find the solutions. And those interventions sort of span from engagement to home visits, and also thinking about the ways in which we can deliver services. Because the important part is also that we're integrating bidirectional communication. This is not only about sharing information with those who need it, but it's also making sure that we're capturing the stories and the experiences of what our patients, our clients, whomever we're serving, we're bringing them back to the policymakers, the decision makers. And that's certainly been a part of the work during this response. As we have implemented a place-based strategy during our COVID-19 response, we've been calling it a hyperlocal strategy. We brought this, particularly during the summer, to really address areas where we've been seeing low testing and high percent positivity. Percent positivity tells us that there's a lot of disease activity or community transmission that's happening. Now we're seeing it citywide, but certainly during the summer we were at a lowest point of community transmission. But we still saw areas where there were high disease activity, where the percent positivity was above 3%. Now we're across the city, we're above 3%, actually above 4%. And really what we saw was that there were lack of testing. There was not enough information that was really circulating. And so really through this approach, we have been really working to make sure that we were working with our community partners, our clinical partners, also working with a number of faith-based organizations to not only bring the resources, but also to be the main messengers. I think that this is going to continue to be important as we think about our citywide vaccination planning. And certainly I'm sure that there are questions just around what the city is doing and planning for. I think this is going to be a really important time for us to really think about these place-based strategies. And I know that this is the very reason why Arthur Ashe even established the Institute for Urban Health, to think about neighborhood investments, and not only think about access, but think about the ways in which we can really address health inequities collaboratively, and think about it through a collective approach. Where we go, and I think this is the next step, will really define our equity agenda. It's part of thinking about our federal administration, and I think that it's very promising that the people have spoken and we were able to really elect an administration that connects to these ideals of addressing injustice and equity. And I think the type of investments that have already been a part of the Build Better Black plan for the Biden-Harris administration leads to the reinvestment that we need around workforce, around infrastructure. And certainly we're paying more attention to how some of those investments will really lead to some of the work that we're doing. The long-term economic recovery relies on this vaccine. This is a new biomedical intervention that's using new technology. The mRNA vaccine, 2 of them now are on the market, and at the speed in which they have been developed, certainly invokes skepticism and a lot of mistrust. And so there has to be conversations and dialogue, particularly about the historical context, but also about the importance of participating in this process and understanding why the importance of taking this vaccine gets us to a new normal. And then last, defining the future also means defining our long-term economic recovery. Thinking about our small businesses, thinking about how we are changing the landscape of our public housing, also thinking about the ways in which we are supporting our public health workforce. This isn't the first pandemic, and it certainly will not be the last pandemic. And thinking about how we're not only supporting our healthcare systems, but beyond that, our primary care, our federally qualified health systems, our community health workers, our doulas, to really be a part of a public health infrastructure that we have not realized before. And those are the things that we're sort of thinking about now. We are certainly eyes on the prize on this resurgence and certainly thinking about this vaccine, but we're also sort of looking ahead as well to what kind of city, what kind of communities that we want to reimagine. And so those are the 3 areas. And I think that those are the ways in which organizations and communities and even students can continue to tap in and be a part of this conversation. So I'll stop there.
Thank you so much, Dr. Easterling, for that timely and engaging conversation and the presentation that you've presented. At this time, I want to introduce someone on our team who doesn't really need any introduction, but I will introduce him. Mr. Umberto Brown serves as our Director of Health Disparities and New Constituency Initiatives, and he has been on the front lines as an activist and a humanitarian as well, like Arthur Ashe. And at this time, I would like to introduce Umberto to facilitate a conversation based on what we have heard so far. So Umberto Brown.
Good morning, everyone. Thank you, my brother, Torian, for that presentation, which I think is important because it connects the essential of what we're facing, right? The historical condition that create the inequities that we're facing, the legacy of it. It established some of the institutions that are impacted by these traditions, these legacies, what James Baldwin would call these lies, right? This construct of inferiority of certain groups versus others. But I think more importantly, you ended with the challenges of what do we do moving forward? What do we learn? How do we integrate what we're living in the 21st century? Because I think the Arthur Ashe legacy is that we have to be a voice that speaks for social justice. And Arthur risked everything he had, including his fame and his celebrity, to bring that voice about justice to the discussion. So that's what we do every day, beyond the disease and beyond the failures of health system, is to make sure that the voices of those impacted by those policies are there, to make sure that when we design policies, when we establish programs, we are adjusting it and thinking of the people who are impacted by that data that you share, the letter of who's impacted negatively from most of this policy. So one of the comments or the question I raised to you is that I'm impressed because of the work that you all have done, including when Dr. Mary Bassett was the lead of the institution, is the role of creating a partnership with community-based organizations and with communities. And I think that we're in a moment where that is an essential practice. As we raise a question about the vaccine and trust, only those trusted relationships will define people participation and level of trust that they're included to benefit from this the same way we get the negative impact of it. So I just want to raise a question again of what is the strategy to include these communities? And that the strategy is not only these fragmented ways of just program, but in co-designing the responses. And I want to put it in the context that we talk about population health, but when we talk about population, I think it kind of homogenize people, it neutralize, and all population are treated the same. So being an immigrant, coming from Latin America, coming from the people who are the African community here, and the issue of immigration status matters. Do you access? Do you think you have the right to access it? And how much of risk you put the rest of your family who's undocumented or waiting to be a citizen when you show up or give your address and those challenges. So I just want to raise some of those things that we face every time these crises come. These are the kind of phone call we receive. Should I trust? Should I go? Should I take my aunt who's undocumented? How do I get support for these people? So I just want to bring that sector in, and hopefully knowing you and some of the tradition, that at least there's a voice there to say we have to bring people in now to have the hard discussion, not when we fail to meet those deadlines. And if there's any other questions in the chat, then we'll follow. But I'd like to hear your comments about some of those issues I just raised.
Yeah. I mean, I don't like following you, Umberto. I mean, I think you're a hard act to follow. But I'll say a couple of things on it. And I think, again, I think you hit all the right salient points. I really do think that for this vaccine plan to be successful, and we have been working on it, our agency has really been thinking through this, we are really going to have shared leadership. There's no question. And Commissioner Chokshi and I have been talking about this for weeks now. we truly understand that this is not going to be something that's successful if government is really out in the forefront every day, all day, talking about the vaccine. I think we're going to have to really activate and invest in organizations to really be the messengers, to really lead in their communities, to think about the infrastructure in which is really going to be able to connect to people, people where they are most comfortable, whether it's in their house of worship or whether it's in their community center. We're going to have to be really innovative here. We're going to have to really stretch our imagination. Things that we have not done before, we will really have to think about in 2021 if we are truly going to achieve the type of herd immunity that's going to be necessary for us to get out of this pandemic. What I can say is that we are building off of some of the successes that we've had in the past, both during the measles vaccine or the measles outbreak, and also during H1N1 outbreak. And some people may know during the H1N1 outbreak, the vaccine took longer. The technology wasn't as advanced as it is now, which is why we have these two mRNA vaccines that have already been submitted to FDA for emergency use authorization approval. We had 50 points of dispensing operations situated throughout the city. And these are emergency operation sites that really allow us to get a throughput, allow people to come through and get a vaccine rapidly. And we're looking at sort of standing up those operations as well. But it's not just going to rely on the Department of Health and Mental Hygiene. We're going to have to really partner with FQHCs and the healthcare systems, really trying to activate community vaccinators as well, to be out in the community and talking about the vaccines. But something, Umberto, that you also mentioned, the starting point is having a conversation. People know that right now there are 3 vaccines that have that we've seen some press release around: the Pfizer vaccine, Moderna vaccine, and also AstraZeneca. AstraZeneca, we know that there have been some challenges and issues. And of course, someone hears that, then what are the issues and challenges for the Moderna and the Pfizer vaccine? And then, you look at the vaccine effectiveness for the AstraZeneca, and by the time that is ready to be shipped out, there are going to be questions. There is a lower effectiveness than compared to the Pfizer and Moderna. And so is that the one that's going to be in the community? Why is the community getting the vaccine with the lower effectiveness? There are all types of questions, and they're not necessarily built on conspiracy. They're built on valid concerns because the trust of healthcare systems have failed Black and brown communities. And I think we have to be honest about that. And I think providers have to be honest about the privilege that they do have by being physicians and care and providers and in clinical spaces, but also they have to own the legacy of distrust and mistrust that has been bestowed upon them as well. And so I do think physicians have to be a part of that solution in repairing that trust in communities, particularly safety net hospitals, community hospitals that sit in Black and brown communities across this city. And so right now we are starting to mobilize and organize Black and brown physicians to start really thinking through our strategy. I think we're going to have to activate other groups as well. As some of you, Fabian already knows, we have organized the Test and Trace Community Advisory Board. And so we'll certainly be activating that group. And there, we're going to really have to think through our organizing principles and get to work here. I see this as the next most important thing in this phase of the pandemic, while we still address racial injustice.
Umberto, you're muted.
Thanks, Torian. Fabian, there's any other question? We don't have a lot of time, so I'd like to get other people. If there's any other question for Torian.
There's no questions in the chat box at the moment, but folks feel free to use the chat box or unmute yourselves to ask any questions that you may have for Dr. Easterling before we wrap up.
Yeah, I just want to say one other thing I failed to share. I think that I've been in some of the discussion with some of the community engagement in some of these COVID-19 vaccine, right, with various universities. And my concern when I talk about the dialogue is that we treat communities like community are illiterates. And so we actually join these things, assuming that all we need to do is go and implement. And I think the issue, what I'm talking about hard dialogue, is I'm happy where you ended, Torian, that we have to convince this community about the value of the science and the safety of it. We can assume they should just come in because they're desperate or they can get paid to do it. These are essential way of having these hard dialogue. I also want to, since another question, is that when we talk about racism, why I respect Dr. Bassett, we invited her a few times to Downstate and other places to speak because there are few people talk out racism or personalize that make people make decisions that they're not even aware that those decisions will impact people negatively. So the issue is not just describing it, but explaining when you have those voices there, how it impact a specific community and why it's important to understand the complexity of those population and their needs, that they don't get stigmatized. So I think that those things will be very crucial in such a difficult moment, because the previous experience when we had to go to the hospital, people were scared to go because they told them there were no tests. Latinos die, a lot of Latinos die at home because they didn't know what to do when they go there. Should they trust the system? So I just raise those issues because I think they're a relevant issue for the future. It's not a discussion of the past, but how will we move forward? So thank you for the comments, and that you will be, I know you will have a voice to make sure that we're in those conversations, because people are raising a lot of questions and we need to answer those questions honestly and truthfully and take their fear into serious consideration.
Mm-hmm. Yeah. Yeah, no, absolutely. I think that I think we need to, and that goes back to one of our core foundations. We need to lead with compassion. Science and equity is going to be important. On the science side, there's so much information that has not been shared about the vaccine. Certainly we've only seen the data through press releases. We have not seen any scientific articles that have come out. And so, I still have just a little bit of, I have questions and some skepticism about the vaccines myself. And I still think that it's going to be really important that we take the vaccine. And so I think some transparency and honesty, even with our leaders, will be helpful. Certainly from an equity standpoint, thinking about the locations, even where we are deploying and distributing the vaccine to really ensure access, particularly thinking about communities that are not as mobile, and really thinking about specific access points for individuals. But the compassion is going to be important. That, certainly with vaccine hesitancy, complacency is certainly a concern. Confidence, Umberto, as you're talking about, because that confidence has not been earned by so many in our communities, that we need to make sure that is something that we're leading with, that we're really trying to regain the confidence of our community. So, absolutely.
Dr. Easterling, I think you just brought up a point that connects to one of the questions that we have in the chat box. Janelle asked, do you think healthcare professionals taking the vaccine will help community members trust the vaccine? A number of healthcare professionals, especially minorities, have indicated that they are not willing to get vaccinated.
Yeah, absolutely. Just to hit on the last point about BIPOC communities not wanting to take the vaccine. Just in October, our agency did what we did. We conducted our health opinion poll, which is usually through text messages and telephone surveys. Those who identify as being Black and African American, only about 38% of those who responded to the survey said that they would take the vaccine. So nearly 70% of individuals are saying that they're not taking the vaccine. That's a large number. And then even across the city, just citywide, even a little over 50%. And so we have our work cut out for us. And so I think any group, healthcare providers, absolutely. Most people really rely on their providers to feel confident in taking a vaccine. When even thinking about some of the more long-standing vaccines that we have, from the pneumococcal vaccine to the measles, mumps, rubella vaccine. You know, they really rely on their providers, the flu vaccine, to really encourage them. And so absolutely, I think we're gonna really have to activate our providers across the city to get in front of a camera, to get on social media, get on their platforms, and encourage people. But that first has to be that they are comfortable with the data. I'm not forcing anyone to take the vaccine. I don't want to be forced to take the vaccine. And I think others who are going to be important, faith-based leaders are going to be important. Elected officials are going to be important. Certainly individuals who participated in the vaccine trial. Dr. Chris Purnell, a good friend of mine, who is an executive position at a hospital, University Hospital in Newark, participated in the vaccine trial and has been on the airwaves talking about why she participated in the vaccine trial, has really been out in the forefront, really talking about that science and data is going to be important here. And certainly we need to acknowledge the long-standing history. We often stop with Tuskegee, but we know that there have been so many other atrocities, from Mississippi appendectomies to Henrietta Lacks, and the list goes on. So we know that these are valid concerns, and so we're going to have to activate any and everyone. Dr. Frazier as well.
So that raises the next question. So in addition to healthcare providers, Joyce Hall asks, how do you see programs and schools of public health involved in vaccine education and in communities of color?
Yeah, so that's a great question. I think that now's the time sort of to think creative about activating a vaccine corps that will include public health students who are out engaging communities, talking to residents about the vaccine, helping individuals navigate to locations. So you know, these are things that we certainly been thinking about, and we're going to be coming to, you know, Long Island University, to SUNY Downstate, to CUNY, to really rely on the students to really help and get the message out.
Thank you. And we have another related question. So we've talked about providers, we've talked about the schools of public health, and we have a question from Cheryl Hall asking, what do you think will be the role of community health workers as we work in our communities to encourage them to be vaccinated?
Yeah, I think the first step, as we learn more about the allocation strategy, and so some may already know that the governor had announced that in this first phase, because New York City is going to receive about 170,000 doses, which will allow us to vaccinate individuals in long-term care facilities, so nursing homes, you know, congregate settings where we have individuals with developmental disabilities. Also, you have adult homes as well. And then also healthcare workers who are most at risk. And so you're thinking about your nurses, your physicians that work in the intensive care unit or the emergency room, or even the EMS providers. Because of their high risk activity, they're going to fall in the first phase. That's phase one, 1A. And 1B, and this is where we, you know, there's still more discussions that are happening. CDC's Advisory Committee on Immunization Practices have not voted on 1B just yet. But I think the area that I think community health workers and doulas are going to be important in really raising and advocating for their staff. Because of the type of work that we community health workers are doing, I think that they need to be a part of the next phase, the 1B. And so I think that's where it starts, to make sure that we're, because many of our doulas, our community health workers, are not connected to a healthcare system. And so that there's not a strong platform for our community health workers to advocate to make sure that they get the vaccine. Again, not forcing it, but making sure that they're included and integrated into the plan. And then once they have a vaccine, then certainly they should be a part of outreach and messaging and education.
All right, we have one final question that we'll close with, and this may be a tough one, but what would be the single best reason to convince communities of color to get the vaccine?
The single best reason?
Yes.
I think the single best reason is to make sure that we are really supporting and giving us an opportunity to fight for our communities and to ensure that we're protecting our loved ones. Yes, there are a lot of questions around this vaccine, but we also know of the horrors and tragedies that we experienced in March and April. I mean, Brother Umberto also mentioned individuals dying at home, phone calls that I received in March of individuals not wanting to go to the hospital. We have to remind ourselves of what we went through, what we experienced. Everyone has been touched by this. And so we do not want to return there. And so I think the single most reason is that we want to preserve life, that we want to protect the life of our loved ones. And I think that's enough to at least have a conversation, to at least be in dialogue, to understand the science and the data, and then make an informed decision. But I think that is where I would start.
All right, and I know that I said that that was the last question, but we have one last question, and then we'll close with Dr. Frazier. So one last question, given that 10% of physicians are Black or Hispanic, should we focus more on HHA, CNA nurses instead of just physicians to bring across the message on the importance of the vaccine? The focus seems to be on minority physicians to bring across the message. Good question.
Yeah, that's a great question, and absolutely. I'm sorry, I wasn't comprehensive. We're talking to, we're going to be talking to NISNA, talking to 1199, because we know the power of labor in New York City. We know the power of their voice and being able to really hit the ground. And so we've already been, reaching out to 1199. We've already been in collaboration with them, doing some work in East Brooklyn through our East Brooklyn Call to Action work. And so absolutely, we'll be working with, nurses, all levels of health professionals. I just need to overemphasize, and this is, I think this is where over communication is going to be effective communication, that we need to think big. I think the challenge here is not thinking big enough so that we can really ensure that we're protecting our communities.
Thank you, Dr. Easterling, and thank you, Umberto, for getting the conversation started. I will pass the baton to Dr. Frazier.
Thank you, Fabian. Dr. Easterling, thank you so much for your conversation. Thank you, Umberto, for facilitating that. Amidst all the Zoom bombing, I thank you all for keeping Grace under pressure and getting us through this. And I thank everyone for coming. I know the Institute has been here for 28 years, and we have had a lot of accomplishments of which we are so proud, but we know that there's still so much to be done, as you have all mentioned, in terms of the things that we need to have done. We are the Institute, we are proud of our programs, and we hope that our programs can be the place that we can move the needle in addressing health inequities. So with our programs, with our students, the next generation of healthcare professionals that will be going out there, we hope that they will be the ones to see the changes that we hope for, the changes that we hope to see in healthcare. With our barbers and our stylists and our community-based partners, we hope that we can continue to champion the cause of the Institute. Before we end, I would like to thank everyone for coming. I would like to thank all of you who continue to support the Institute. Had we been in person, we would probably have had lunch at this time, but we're not. But I still thank you for taking the time out of your day to be here with us. I would like to thank the communications folks at SUNY Downstate, Dawn Skeet Walker and her team, especially Sean Till. I would like to thank Dr. Kathy Powderly, who has been a staunch supporter of the Institute from its inception, because the Institute was founded in her division. And I would like to thank all of those that have come out today. I'd like to thank my former CEO, Dr. Ruth Brown, who is here today with us, all of our community partners, all of our friends. Brett, I thank you so much for your opening remarks. And again, I thank our Arthur Ashe team, the staff that makes my work easier every day. And so I thank you, and I look forward to the other years ahead for the Institute, and we look forward to being in person. Maybe not at the next one. We look forward to being in person soon again. And so enjoy the rest of your day, and thank you for taking the time once again.
Thank you. Have a good one.
Thank
Bye-bye.
you.